Barnes. Pleasure to be here with you today. Bear with me for a moment while I introduce you. You are the Clinical Program Manager for CeDAR Recovery Center at the University of Colorado Hospital.
Mm-hmm.
You are a faculty member at the Love and Trauma Center and one of their core trainers of the CAR trauma model.
Yes.
Great. And
Nice to be here.
Wonderful. We are here today to talk about the integration of trauma in the addiction recovery field.
Mm-hmm.
So I'm just going to throw that out as our beginning question. Can you just open us up? What about the integration of trauma and addiction?
Well, I think first and foremost we have to be very cognizant of the fact that for years we've really kind of focused away from trauma in the addiction world. We've spent the vast majority of our time saying that the care can be trauma-informed and that it's imperative to understand the trauma and understand the trauma symptoms, but it's been much more about safety in the environment. And we're really beginning to recognize the fact that there's a lot that we can do to really begin to treat this relationship between trauma and addiction on a daily basis.
You mentioned trauma-informed. I know you've spoken about the difference between trauma-informed
Mm-hmm.
and trauma-integrated.
Mm-hmm.
Can you briefly just get clear on those differences for everybody?
Trauma-informed is really a philosophy of care, looking at the treatment environment. Is it safe enough? Are the providers, have they done their own trauma work? Are they non-reactive and not a lot of countertransference? And with a primary focus on keeping things safe enough for people to do their own work. Trauma-integrated is really a relatively new process where we're really looking at the impact of trauma on the actual addiction treatment process, and that individuals who have not been treated for both within certain limitations tend to have a much higher relapse rate, a much higher treatment failure rate. So trauma-integrated work is about being able to identify very specific trauma needs, trauma treatment needs, and addiction treatment needs, and integrating them into a form of therapy.
What happens if someone in treatment does not do that?
Well, the statistics are pretty clear that relapse is a very common experience for those individuals. And I often tell patients that if they've had multiple treatment experiences or treatment events and continue to struggle and continue to relapse, and they haven't really spent some time looking at their trauma history, both childhood and adult traumas, that it's very important that they do that.
So you're saying that the reason often for relapse is the trauma?
Absolutely.
Yeah. Can you explain a little bit more?
Well, I mean, I think that it gets into a much larger discussion about what trauma is and how trauma impacts the body and the nervous system, and that looking at memory systems and beginning to really kind of look at that in order to make really healthy recovery-oriented decisions. And that's really what staying sober is about, is utilizing coping mechanisms and maintaining social systems and support systems. That it's, particularly in the treatment environment, it's imperative that they're able to learn these things and develop these skills. And if we don't kind of treat what we call these sort of proceduralized responses to trauma memories, these escalated emotional dysregulation, anger, depression, dissociation, that are for an uninformed counselor are very rampant in addiction treatment, and they get in the way of a person actually hearing the what I call the recovery message, which is learning all of the 12-step material that they need to learn, gaining insight into the impact of their addiction on their life. If a counselor doesn't understand what memory system a person is working out of, they don't really know what kind of therapy to do with them. And so if someone is highly escalated, you don't do talk therapy. If someone's escalated, you use a therapy like the car model.
And what I'm hearing is that these things that get in the way of hearing the message, like dysregulation, anger, etc., are all symptoms of unresolved trauma.
They are. And so, this idea of a person is out of treatment, they're actively going to meetings, they're working with a sponsor. If they haven't worked on some of these other sources of dysregulation, these event memories, these kind of traumas from their background, that as they get triggered, and all trauma survivors are triggered from time to time, that it takes them out of a process that allows them to utilize those recovery-oriented skills that they developed, and takes them into a kind of a trauma response. And that's when relapse happens. That's a long answer to get there, but
Yeah.
that's when relapse begins to happen.
Got it. It reminds me of something you spoke about in one of your trainings around the triangle theory. I don't know if I'm remembering that correctly.
Yeah, I mean, I tend to look at addiction treatment as a more of a triangle, with addiction at the very top of that triangle. It's really what we're trying to target and what we're trying to manage. But at the foundation of that triangle is attachment and trauma, and that so much of addiction treatment is the development of a healthy therapeutic relationship, of learning to manage those sort of attachment-related responses that create distance, or that take them out of dealing with the things that are most important. And so for decades we've said you don't work on the trauma until the person's been sober for an extended period of time. And what I'm proposing is that if we don't work on the attachment and development of a therapeutic relationship, and the trauma and those proceduralized responses that happen, or those symptoms that happen when a person is triggered, we're never really going to get to the addiction piece. And so it's one of the reasons that I feel really fortunate to be at CeDAR, but also at Love and Trauma, because I think that the CAR model, the first two phases of the CAR model are about the foundation. The first phase of being resourcing and really being able to help people to sort of de-escalate when there's that affective response. It's so typical for the attachment stuff, but also for the early trauma response. And personally, I think that the second phase of the CAR model is the most important one, and for the addiction world, and that is those relational abilities, that ability to say yes when I mean yes and no when I mean no. And everyone leaving a treatment center is forced with being able to say no to people, to family members and loved ones and dealers and everybody else. That at CeDAR, we're actually beginning to use the CAR model in a group format. And this idea of having individuals in a group begin to kind of resource together and practice resourcing with each other, and looking at what are the situations that they envision when they graduate or when they leave CeDAR and move into the next phase of treatment that's going to cause that escalation, that's going to cause that sort of proceduralized response, and beginning to practice together and then debrief it. And then we look at relational abilities and what are the things that are going to be hardest to say no to.
And these are all a core part of the CAR training?
These are the first two phases of the
First
CAR
two
training.
phases.
So what we call ACAR, that idea of addiction CAR. And I think for many of the people that I work with in my private practice, it's much harder to say yes to things as well. And that idea of, they're at a meeting, they have a sponsor, a group of people are going out afterwards, and they want to go home and just get away from it. And it's really hard for them to say, yes, I'm going to join in, I'm going to engage in this recovery support system. And so being able to work on saying yes is every bit as important as learning to work on saying no.
Great, making a lot of sense. Any last thing you'd like to say to a lot of the audience who is watching? Many of them have attended a one-day training put on by you and Mr. Saj Rosvi. Any briefly last things you'd like to say to them?
I think two things. One is it's imperative that you understand trauma memory, how it works, and memory systems, so that you do talk therapy when someone's in a declarative memory system. You can do behavioral therapy when they're kind of reacting procedurally. And we use CAR, and we also use some DBT. There's a variety of things we use. And that there's that you use trauma therapy when someone's really in a sort of a trauma memory system or an event memory system. And then the last is when I talk about being able to hear the recovery message, I'm really talking about the idea that those proceduralized responses to traumatic events take that person out of the ability to hear the things we're trying to get them to hear. And if we can integrate that in, then I think we give people a chance to actually understand far greater and far deeper, like, how to implement those things.
Great. Dr. Barnes, thank you so much for being here today.
Sure. My pleasure.